Hello, and welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shamagam. To renew is to resume activity after an interruption. And as anyone who's ever failed to keep a New Year's resolution knows, sometimes it's good to have a partner to guide you along the way when you're trying to build a new habit. The manuscript we will discuss today is Effects of a Resilience-Building Energy Management Program on Fatigue and Other Symptoms in Systemic Sclerosis, a randomized controlled trial. It was published in Arthritis Care and Research, and a link to the manuscript and disclosures are in our show notes from today. It's an honor to be joined today by Dr. Susan Murphy and Ms. Mary Allor, two of the manuscript's authors. Dr. Murphy is a rehabilitation researcher focused on optimizing the management of chronic conditions. She was trained as an occupational therapist and is particularly interested in advancing telehealth and rehabilitation for people with scleroderma. She leads the Behavioral Studies branch of the University of Michigan Scleroderma program and the Scleroderma Peer Mentor program there. She is also an expert in patient-oriented and community-engaged research methods and social and behavioral clinical trial methodology. Ms. Mary Allor is a peer mentor health coach at the University of Michigan and an IT consultant and website developer. She's also a specialist in scleroderma and has co-authored several manuscripts on scleroderma management. Welcome to the show, Susan and Mary.
Thank you.
Thank you. Thanks for having us.
So, Susan, before we delve deep into your manuscript, I wanted to ask a little bit about how you came to be working with and co-authoring manuscripts with Mary. Would you mind sharing with our listeners the story of how you first met?
Sure. This takes me back because I met Mary years ago at a scleroderma event that was sponsored by the University of Michigan Scleroderma program. And they have this great patient day where patients and peer mentors and partners that work in the program come together, and researchers have the opportunity to talk to patients and others about what they're doing. And it's a really good opportunity to really explain the science to people that are interested in learning what we're doing to help manage and hopefully cure scleroderma someday. A variety of basic to clinical, the translational researchers come and present. And that's where I met Mary and learned that she was a peer mentor and that we had a peer mentor program. And Mary has been instrumental in growing that program for many years.
So Mary, just to clarify for our listeners, you've been living well with scleroderma for some time. What made you want to work so closely with the Michigan Scleroderma research team?
Well, when I was diagnosed with scleroderma 12 years ago, I was really seeking support from my peers, others who had this rare disease. But unfortunately, I couldn't find much valuable support out there. And that's when I reached out to my scleroderma specialist at Michigan Medicine, Dr. Dinesh Khanna. He was so very supportive of me, and he put me in contact with two other patients who had asked for the same support. Since then, we've started the peer mentor program, and it's grown to a team of us participating in research and health coaching. So I've been really interested in research since I was diagnosed, and I participated in all of the trials that I was eligible for. So I'm grateful that, as a patient, I've been able to participate in both sides as a patient and in research. So
yeah, that's really cool. And I feel like this partnership is actually very invigorating for research often. So Susan, I'm going to take us back to you. Set the scene of this manuscript for our listeners. What burning question did you want to answer with this research?
Well, I've been working for many years in chronic symptom management. So I knew that there were many ways that we could help people with scleroderma. And really what I wanted to do was work that was very valuable and relevant to people. So I started talking to a lot of people with scleroderma about their day-to-day lives. And that's where people were really talking about having this heavy fatigue burden, and they couldn't really get it addressed at the doctor. And it's not something that is easily clinically managed. There's a lot of things that people can do themselves to reduce fatigue. So it was a great opportunity that I thought that I could help build evidence in this area and address something that was important to people. So really trying to tailor what we know that works in the evidence to people with scleroderma And the other thing is because scleroderma is rare, it's a little more challenging for people to know kind of what to do for their symptoms. They can become socially isolated and have some additional challenges that can affect their mood and motivation, like trying to explain the disease to others and having challenges that may look invisible to others. So I really thought that a self-management focus and having peer health coaches could be really important for people with scleroderma because there's so many positive role models around that can inspire others.
Yeah, it's wonderful to hear. And Mary, you were instrumental in designing and developing the resilience building energy management to enhance well-being intervention. You call it Renew, that you tested in this study. What was it? And how did you yourself design and develop it?
Well, Renew is a team approach. I hate to say that it was a lot of us participated, and especially the patients part. The Renew intervention, it's based on the concept of patients learning to self-manage and gaining these skills and strategies to help them find relief for their symptoms. The overall overarching concept was to help them increase their confidence that they had the ability to manage their symptoms. And that's what we do in peer mentoring too. We just want to give them the confidence that they're not alone and that they have a part to play and they can do things that can really help them engage more fully in their life and offer value still. That, again, our main thing is that we want to stress that they're not alone. They can partner with other people, their healthcare providers, and then we want them to learn that they're the most valuable part of their healthcare team. The other part of it was that it's online. So people didn't have to travel to meet with a coach. It was very accessible for people. And we were able to reach people that probably wouldn't have ever been able to find this through their local scleroderma center or even their local physicians. But the framework of the whole thing was to provide resources to participants and to meet with them. We met with participants, health coaches met 9 times over a 12-week period. And we offered support and accountability, which is very important to keep, people knew they had to meet with their health coach. So they had to do their goals. And we worked in 7 goal areas: exercise, pacing themselves, relaxation, being positive, taking care of their bodies, healthy eating, and sleep.
It's really good. It's really important, I think, as we look after people with chronic illness, to remember how vital it is for sort of health and wellness to give people a little bit of agency over the things they can control. And I really like this intervention for that reason, is that it's truly a partnership. So Susan, you wanted to test this intervention in a rigorous trial. Tell us about the design of this study. What did you do?
We recruited people who were diagnosed with scleroderma, and they had to have at least moderate fatigue to participate because that's really what we were focused on, this energy management or fatigue improvement. And we randomized 173 people into the trial to receive the Renew program, or they were in a waitlist control group. And we did that in a 2-to-1 ratio where twice as many people got the Renew program as opposed to the waitlist control, because we're really most interested in understanding the effects of the program, but also to be able to have a meaningful comparison group. And as Mary said, the Renew program, we had online materials and an app. So they had a website or an app that had equivalent information, but the app, they could track their goals. And the health coach's role was really to help them set realistic goals and be an accountability person for them to advance week to week. They met with them more often in the first half of the program and then biweekly in the second half, so weekly to biweekly. And we assessed fatigue and some other symptoms that we thought would improve and some other qualities at the beginning, middle, and end of a 12-week period.
And to be clear, everyone eventually got the intervention. It was just during the study period, you waitlisted some people and gave the intervention to 2/3 of the people. Is that right?
Yes, correct. So the people in the control group didn't get the full intervention, as in they didn't get all the 9 sessions with the health coach, but they got all the materials and they were able to meet with the health coach at least one time to set up goals and to talk. Although not that many people took us up on that. We gave all the materials, but not too many of them wanted to meet with health coaches.
So tell us, how many coaches were in the program? And maybe this is a question for Mary, actually. How many coaches did you have? How did you train them?
We had 3 coaches, all who have scleroderma, and we were trained by Susan's team in motivational interviewing, which was new to a lot of us because a lot of us aren't coaches by trade or anything like that. So we were trained in motivational interviewing, and we also did a pilot study before we started the actual real study where 2 of us got to practice. I think we each had 10 participants each, and we also tried to sit in on other people's calls, on our other coaches' calls to see how they do it. And so we learned from each other. I think that was in addition to the training that we received. We learned from each other. We saw how others did it. And that helped us a lot to get feedback from each other.
Yeah. And were there evaluations or assessments to ensure that every subject in the study received coaching of a similar caliber across all of the participants?
Yes, absolutely. We had a coaching manual that we followed. So we made sure that we all did the same things in each week. It was broken down by weeks of the 12 weeks of the study. And we also videotaped, which every coaching session was taped through Zoom. And it was then reviewed by an external person to see how we were doing and if there were things that we weren't staying in line with. So we knew that we were being kind of watched, which is good because it helped us keep us accountable as health coaches.
And can you, Susan, tell us a little bit more about the randomization of the participants? Did you try to pair each health coach and coachee based on scleroderma subtype or any other characteristics?
So when we were thinking about this, the biggest consideration was gender. In fact, because we know that men have a different experience with scleroderma than women. We've done a lot of focus groups with women and men separately, and they have different issues that come up. And sometimes men feel more comfortable talking in male groups because they're the rarest of the rare. It's like a 4-to-1 ratio of women to men that have scleroderma. So it was very important for us to have a male health coach. And then when we had male participants, to match them as much as we could with our male health coach. We also considered the type of scleroderma that people have because we had health coaches that had either limited or diffuse scleroderma, but that really wasn't as big of an issue. We were trying to really accommodate schedules more than anything else. So we tried to match people by when they were available and really didn't hear anything about having a mismatch with health coaches. Everyone seemed to love their health coach regardless of who we gave them. So it worked out.
That's actually helpful to hear. So tell us a little bit about the demographics and the patient characteristics of the patients in this study. Were these patients with new diagnosis of scleroderma, or how many years of disease did they have?
We have pretty good split, actually. Just over half of the participants were considered what we call early in their disease, which is less than or equal to 5 years of getting diagnosed. We had mostly females in our sample, which was around 93%, which is a little higher than what we usually have in our other trials. We think that women want to participate more in this kind of intervention than men. We did a lot of recruitment for male participants and just found that females were just much more apt to sign up. We had a mostly white sample. We tried to really recruit diverse groups, and that's kind of who we got, which was not as good as what we'd like, but still pretty representative of what it looks like for people with scleroderma nationally, if we could get a little more men. But we did have people from 7 different countries. And that was kind of cool. And because everything was remote, we were able to recruit very broadly. And about half of our sample had diffuse scleroderma and half had limited scleroderma. Most people had pretty high fatigue and other high levels of symptoms like pain and depressed mood when you compare it to the US population.
Yeah, well, so I'm really interested in this worldwide reach that you had. So people didn't need to receive care at the University of Michigan to enroll in your study. How did that work? How did you actually reach people? How did you recruit? And did you run into any issues of being able to fully verify the details of somebody's scleroderma? Or what did you do? Get health records from them?
Yeah, it went surprisingly well, maybe better than we thought. We did require people having to send us some documentation of a diagnosis of scleroderma. Sometimes it took a little bit longer from some people than others, but we accepted different ways if they had a patient portal snapshot versus more of a letter from their doctor, or there was lots of ways that we could verify that. We didn't require medical records. We just wanted the diagnosis, and they self-reported their disease duration. But because everything was done remotely, it really allowed us to do this. And as long as they could speak and read English, we were okay to recruit them. So we did have people from 7 different countries. We had more representation from countries where we had rheumatologist colleagues or strong scleroderma organizations that could help us recruit. But we got a lot of good recruitment from social media groups. We have a Facebook group called the Scleroderma Backers. We went to many support groups and posted there. We did podcasts. We did many different forms of media and really didn't have a problem with recruitment, which was very lucky for us because most of our recruitment was done right during the throes of COVID. So when people couldn't meet others in person, they could do our study.
Yeah, no, and I wonder whether that is why people really appreciated this intervention during that time as well, because it was an incredibly isolating time for everyone, right? And especially if you had just received a new scleroderma diagnosis, I mean, I think it was a really tough experience. So just to be clear, because this was health coaching, it wasn't a medical intervention. So it wasn't like a telehealth visit or a visit with an occupational therapist where you would have needed licensing for those health coaches. There was no concern about them seeing people across state lines or even in other countries. Is that correct?
Yeah, that is correct. And testing out peer health coaching, we're doing it in a research study, and we can completely fund it and do it in our own vacuum of efficacy testing, which is great. But really what is more challenging is to figure out how to sustain this in a system. We're not billing for services here, and the types of peer health coaches that are funded vary state by state, and they're for specific purposes. So it's really not clear how you would license someone and scale it up nationally. Really what we wanted to do here is just to see for proof of concept if this type of service is effective, and then try to figure out how we can sustain it.
Okay, so let's talk about efficacy. What were the outcome measures that you studied?
We used what are called promise measures, which are very familiar to researchers and probably not as familiar to non-researchers, but they're common, valid measures that many researchers use. They were developed by the National Institutes of Health to kind of have a common metric across studies, and they have some very nice properties of comparing their scores to the US population. Many people with scleroderma would be familiar with these assessments if they receive their care at scleroderma specialty centers because they're used so often in trials and studies. We were interested in measuring fatigue, pain interference, which is how pain interferes with life, depressed mood, and also resilience, because we didn't really mention it, although it's in the title of our intervention, is that this is a positive psychology focused intervention. So it's really focused on things like gratitude and practicing the positive and things that aren't always in chronic symptom management interventions, which we also think was an effective approach because it's a little bit more positive and fun instead of, you have this heavy burden of an illness and how are you going to manage it day to day. So we wanted to see if people's resilience improved because we're also working on helping people cope better, managing their other stressors and symptoms. And we used a validated scale to assess resilience.
Yeah, no, and I think it's so important because oftentimes in the kind of clinical visit, the interaction with the clinician is very focused on targets and metrics and measures of outcomes and not really focused on how is someone living with the chronicity of the disease and managing those other complications. So it's so interesting to hear about this intervention. Mary, I want to take the conversation back to you now because I'm really intrigued to know how the coaching worked. Tell us a little bit about how people were able to keep up with the coaching. Did most people complete their full coaching course? Did you have any people who dropped out or were just too busy for the coaching? Tell us more.
Yeah, definitely. We had great participation in all the participants. We had 85% of the people in the program attend 7 or more of their coaching sessions. And there was a total of 9. So we had great participants. They were really engaged. They enjoyed meeting with their health coaches because I think they felt that support and that they knew they weren't alone. The participants really, they showed up. If they had another commitment or even if something was going on health wise, we would reschedule it. And again, people came to our sessions. I even had one lady who was hospitalized, had to be hospitalized during the intervention, and we had to reschedule, but she still got on her iPhone and she still met on Zoom in her hospital gown because I think we gave her that support even when she was in the hospital and maybe she couldn't fully work on all of her goals, but we would adapt. And we would work on, like Susan said, some positivity goals or even have her practice deep breathing. We'd set a new goal for her because of the situation that she was in. So again, people really wanted to show up and just talk to somebody. Personally, I had maybe 1 or 2 participants who dropped out. And that was because I remember she was not feeling well and she was just having a hard time. So very few of the patients dropped out.
Okay, so Susan, walk us through the results. Tell us what you found.
Sure. So in comparing to the control group, people who completed the Renew program had a reduction in fatigue that we consider clinically meaningful, which on our fatigue measure was 3 or more points of improvement on the fatigue scale. But they also had significantly improved pain interference, improved depressed mood, and increased resilience. And this is over a 12-week period. One of the most interesting things we found was that there was a difference depending on how long they had scleroderma. So people that were earlier in their disease had the most improvement in their symptoms compared to those later in the disease. And we dug into that a little bit more and we did some follow-up interviews. We learned that most people really enjoyed the peer health coaching more than anything else in the program, which was not really surprising based on a lot of things that we heard from people. But they wanted the health coaching a little bit differently depending on their disease duration. So people that were newer to scleroderma actually wanted more time in between their health coaching sessions. So early on, they had weekly sessions, but they thought that the weekly sessions didn't allow them enough time to practice the behaviors related to their goals. Whereas people later in their disease kind of knew a lot of what we were teaching and knew some of the topics like pacing and relaxation, but they actually wanted more health coaching because they used it more as accountability. We had some good thoughts for the future about how to modify based on disease duration.
And when you designed your study with that waitlist kind of control group, the placebo group in the waitlist group, you didn't then later measure the efficacy of the intervention given at a later point in illness, right?
Right.
You weren't then able to go back and look at that. So that might be a kind of cool thing to look at in the future, maybe.
Yeah, that's a great idea.
So Mary, what did it feel like for you and your colleagues, the other peer coaches, to see the impact of this intervention that you'd come and designed together on outcomes for other people living with scleroderma? How did it feel?
Well, it felt very fulfilling and motivating. We got to see these patients or participants gain confidence every week, and we saw them grow and become less isolated. For all of us, it put us back to when we were in that position of maybe newly diagnosed and not knowing what to do. Or even for us now that we are many years into the condition, and it helped us to see that there are things that we could still tweak and we can still work on. And just, I guess, everybody gaining more knowledge and seeing that was just, again, very, very fulfilling.
Yeah, I bet it was. And I kind of really fascinated to see where you take this, which brings me to Susan. What's the next step for this study?
Well, we have been working to obtain funding to partner with the National Scleroderma Foundation because we thought we could offer the Renew program within the foundation chapters, perhaps as a cycle. So everyone would sign up for kind of a cycle of Renew. And that way we could train the health coaches. We could help the foundation with the training of the health coaches and monitoring to keep the quality up, but to do it within the chapters so people could experience it within their own geographic region that they live in and with health coaches from those areas. So if we can do that, we have a large implementation trial planned, and it would be really an interesting way to think about management and how we can use these advocacy foundations to support what health systems are doing. So, maybe we don't have to do everything within the health system, but we can use these other partners in a powerful way.
Yeah, no, I think that's really important. I love the idea of kind of cohorting people as well. I think that could work really well. So before we close, I wanted to learn a little bit more about your partnership, Susan and Mary, through this journey in medical research together. So Susan, I'm going to start with you. What motivated you to become a rehabilitation researcher, and then why scleroderma?
Well, I started out as a clinician, as an occupational therapist, and I love occupational therapy. But I think I've taken the path that many clinicians take is you get frustrated by not knowing if what you're doing is working and how you can optimize your treatments. And that really drove me back to school and to research, which I developed a deep love for. I started researching symptom management in various chronic conditions about 20 years ago, but I really didn't know anything about scleroderma until I was actually at an occupational therapy conference with a friend who was newly diagnosed with scleroderma and saw her go into a full flare while we were together for over a week period. And it really showed me that it can be a very challenging diagnosis. And kind of serendipitously, University of Michigan has a wonderful scleroderma program. I got to partner with Dr. Dinesh Khanna and the peer mentors, and it really just developed into something that's been a wonderful research program and partnership.
Oh, that's a lovely story that I never knew that background. So thank you for sharing that. And how has your interaction with Mary and the other peer coaches shaped your research?
I've always wanted to do patient-oriented research, but really didn't know what that meant until I started to develop these bonds with Mary and our other health coaches. And these people are like equal partners. They're people that have complementary expertise like any other kind of co-investigator that you would have that has complementary expertise. And it's been such a wonderful, meaningful process for me to be doing this with scleroderma research. I just feel very fortunate because I feel like we're all using our best skills. Mary has many talents, which really helps us because other than being a wonderful health coach, and she's very humble about many things, but she also has a lot of IT skills and helped us in our website development and in our app development. And we had to work with patient partners to develop our app so people could access the buttons and have it function the way that they wanted with limited hand mobility. And Mary was part of all of those things. So it's just been truly valuable and enjoyable for me.
Yeah, and so important because you know that a typical software engineer would never think of those things. So Mary, what drives you and what drives you to be so involved with this research?
Well, other than Susan, thank you, Susan, so much. Susan and her team, but really, it started out with me offering, first, and I was in clinical trials. I'll participate because I want to help hopefully find a cure or find treatments. And then it grew into helping support patients with information and just supportive information one-on-one. And then after with the research, I learned I could bring my perspective to research and help others that way, kind of behind the scenes type of thing. So that and Susan's team and working with her has been amazing.
Yeah, and I want to pick up on that because it's something that historically hasn't been typically done in clinical trials and in design of research studies. And I'm wondering if you, Mary, have advice for other people who may be living with chronic illness and want to follow a similar path and really help the physicians and researchers who are studying a disease incorporate a patient perspective into clinical research.
I would definitely say to ask, put yourself out there, ask them, how can I help? How can I offer support to other patients? And try to partner with your healthcare team. I think that it would be so important and really offer that side that maybe sometimes is not there and lost in your treatment plan. And it'll help you too to feel like feel more empowered about what you're doing and how you're taking care of your own health.
Yeah, and I really kind of emphasize that it's something that's typically missed, that people don't always think that there are, obviously the scientific experts, but there are experts in scleroderma and they are living with scleroderma.
Right.
And that should not get missed. So, Mary, did you ever imagine that you would co-author all of these manuscripts?
No. Never in my life would I have imagined this. I'm an IT professional, which means I've always been behind the scenes, crunching away at my computer. I never thought my skills, number one, would be important or needed in research. And of course, I never thought my perspective would be important. Just because, again, patients, we tend to put ourselves kind of behind and we think like, oh, I'm just the patient. But, we have a part to play in this kind of realm. And I'm so happy that I've been able to be a part of it.
Yeah. And last question for you. What's the secret sauce? What was it about your relationship with your medical team and with Susan in particular, do you think has made this so collaborative? Because it's been a really amazing and fruitful partnership.
Yes, I think it's our open and transparent team approach that Susan has allowed us to have in our whole team. We have the other patient partners and we're all very open. We share our authentic selves, good or bad, sometimes, too much information, but we're very open to sharing that. And we're valued. We're allowed to bring our talents, our skills, and our experiences to the team. And I think the other thing is, again, with the whole open communication is that we have learned a lot from the researchers from Susan's team that it's okay to put yourself out there, get feedback on what you're doing, and provide feedback to others. Like in the example where I told you that we would watch each other's videos or sit in on interviews, we were open to feedback. And I think that's very important.
Yeah, I always think that word should actually be rephrased and it really should be feed forward, right? It's going to change your future behavior because you can't change the past.
Right.
So last question for you, Susan. You are also a member of ARP, and I think actually that's how we first got to know each other. Can you share with our listeners a little bit about the Association for Rheumatology Health Professionals and what is it and who can become a member?
Yeah, so the ARP is what we call the interprofessional division of the American College of Rheumatology. So it's really all the non-rheumatologists, rheumatology professionals. We have physician assistants, pharmacists, nurses, OTs, PTs, social workers. There's even a group of rheumatology administrators that are part of it. And really, it's a great network of people. I belong to ARP. It was called different things over time, but ARP is the latest, kind of most streamlined title. We're a subgroup that I belong to for about 20 years, and it's by far the best organization that I belong to. And I volunteer there every year in different roles, which is how we met, Vicki, doing some program planning. But it's such a great organization because the chance to connect with rheumatology leaders and colleagues from all over the world. The annual meeting is really the conference that people go to, but people that would want to join, it's on rheumatology.org. And if you're a researcher, they have a lot of great research grant opportunities, which is another plus. But I do want to mention when we were talking about Mary, this sort of ties in to the annual meeting, that Mary actually presented last year at the annual meeting. There was a patient special session and she presented on being an advocate and health coach. And it was an awesome session where patient advocates presented. So hopefully we'll see more of that and have our patient partners a little more included in the meetings.
Yeah, it would be lovely to see it and maybe an opportunity for them also to join in the activities of ARP and the ACR, right? So perhaps you need a category for peer health coaches as well. I want to thank you both, Susan and Mary, for telling us about your wonderful research and your program of peer mentoring. What an amazing resource for people living with scleroderma. And I'm excited to think about how this program could grow and both help people live well with scleroderma around the world and then perhaps be expanded to other chronic conditions. Thank you.
Thank you. It's a pleasure.
So today, a huge thanks also goes to patients who contribute to clinical research by enrolling in studies and sometimes by designing their own interventions. This work is really important, and we should never underestimate the power of lived experience. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at ACR Room on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.